Thank you so much, sir. Can I share my screen, please? So, at the outset, good evening to all, and I would like to thank the organizing team for giving me the opportunity to speak on this important topic. That is genotype-based treatment option in non-small cell lung cancer, and I would be talking on the three most common mutations which are seen in the non-small cell lung cancer. We all would agree that this particular aspect of lung cancer management has definitely seen or undergone significant evolution in last 1.5 decades. Lung cancer remains one of the most common cancers across the globe, and in India also it's the fourth commonest cause across both these sexes. As the numbers are increasing, so is the complexity in the management of the lung cancer, and the decision making is definitely based on the histological subtype, genotyping of the predicted biomarkers, and all of them are interlinked and do not work independent of each other. For molecular testing, I would just like to share this thing that it is tissue done by the either tissue or the liquid biopsy. If we get the tissue, that's the best sample we can get. We are even doing the tests, which are methods which are continuously evolving in the testing, and we know that we want something which has a fast turnaround time, cost efficiency, ability to perform on the clinical available samples. So according to that, we have various testing methods like IHC, PCR, FISH, and NGS, which gives us the results. So non-small cell lung cancer has evolved from a single disease to many molecular defined subtypes. And these subtypes has given us diagnostic, therapeutic, and prognostic challenges. And we all know that current therapeutic profile of the lung cancer has three broad options, that is the conventional chemotherapy, targeted therapy, checkpoint inhibitors. But things are changing so fast that we are always on our toes in the decision making as to what are the established and equally important is the novel molecular based treatment strategies. And then for that, we need how extensive we need to get the genomic testing done, which has to be standard in the current era. As the things are getting complex, we see that on the left hand side of the slide, the inner circle says that we are more the inner circle has a different molecular landscape, and the outer circle, which encompasses of the Asian population, we have the commonest mutation, that is the EGFR exon 19 and del19 and L858 mutations, which are the commonest in the Indian population. Besides that, we have ALK and ROS1 mutations along with the MET mutations. The evolution of the drugs has also been significant right from the almost for 1.5 decades. And we have newer drugs, newer options, which are giving us better efficacy as well as the better penetration in the CNS, which was considered as the significant prognostic factor. From the past to present, we have evolved. We were almost at the 10% 5-year OS in the stage 4B disease. However, when we have various mutations in the non-small cell lung cancer in the metastatic setting, we are almost heading towards a significant PSA, PFS, and OS benefit when they are associated with ALK, ROS1, or other mutations. Why these mutations are important? Because we have seen that the lung cancer is more of a disease of the elderly population. However, there are significant differences as far as the epidemiology in the Indian setup is concerned, and we have very less number of patients. Almost in the Western population, we have less than 2% of the patients in the less than 40 age group. But one important factor which has been seen in this study, that in the younger age group, we find more of EGFR, ALK, and even the non-actionable mutation besides the ROS mutation. What is important on this oncogenic addicted non-small cell lung cancer is the brain metastasis incidence, which has been significantly seen in 36% of the ROS1, 34, almost 32, reaching up to 40% of the patients in the different mutations. But higher brain metastasis in the oncogenic addicted non-small cell lung cancer has been seen in the different mutations, and there is a higher cumulative lifetime risk of developing the disease if the metastasis is not present upfront at the diagnosis. We all know the prognosis of the metastatic non-small cell lung cancer varies. With the brain metastasis, we had original GPA, that is the graded prognostic uh, assessment, which had 4 factors. That was the age, extracranial metastasis, uh, KPS status, and the number of brain mets. So according to that, we were almost reaching the 7 months of survival in case of upfront brain metastasis when they were present. But when we have added certain markers in the GPA, which is known as the molecular GPA, when we add EGFR, ALK, and certain other markers, we are reaching up to 4 years in case of GPA when it's more than 3.5 to almost reaching up to 4. So these metastasis, brain metastasis, despite originally being a poor prognostic factor, have given us these mutations have given us a better survival when the TKIs are offered to the patients. So considering the poor prognostic factor which is associated with the intracranial brain metastasis, we were looking for some TKIs with a higher intracranial penetration. So we see that osimertinib in the anti-EGFR and the lorlatinib and along with the alectinib, they have got a higher CSF penetration rates. So which definitely has given us the increased or the better intracranial response rates with the osimertinib and other next generation TKIs which act against the ALK mutation. One thing today I thought I would like to highlight is the genetic heterogeneity which has been seen in the primary versus the brain metastasis. So it is something like heterogeneity or the discordance when it was seen, which is seen in the breast disease, and every time the disease progresses and we need to do the biopsy to see the discordance. However, the discordance here may not be associated with the same mutation, may be associated with the different mutations. So we have seen that there's a 53% genomic heterogeneity between the primary and the brain metastasis tissue. However, this was seen most commonly in the EGFR and the KRAS, which is almost 10%. But in ALK translocation, there was a 100% concordance. The EGFR pathway, to discuss the EGFR mutations which are seen in the exon 18 to 21, commonly seen in 10 to 30% of non-small cell lung cancer. However, in the Indian population, various studies have shown that the incidence is almost 25 and reaching up to 60%, which is more commonly seen in the never smokers, adenocarcinoma, female, and Asian population. The two commonest mutations are DEL19 and L858 are in the exon 21. Rarer mutations are seen in the exon 20, exon 21, exon 18. We have 3 different generations of the drugs for the EGFR mutation, that first generation, second generation, third generation, which have specificity or reversibility when they are binding with the EGFR receptor. So we have, in the first generation, we have erlotinib and gefitinib, which reversibly binds to the wild type and the mutant EGFR and has almost nil activity against the T790 mutant variant. The second generation, we have afatinib and dacotinib, which has an irreversible covalent binding to the EGFR, and it has a broad activity to overcome the EGFR and TKI resistant mutations. Osimertinib, which is the most effective drug as on date, has got a specific activity for the EGFR T790 mutant, and it binds irreversibly to the mutant EGFR. So considering these factors, NCCN, the latest guideline says that for EGFR, DEL19 and the L858 mutations, osimertinib is the preferred first-line treatment option. If the disease progresses on osimertinib, then it depends whether the disease is asymptomatic or symptomatic. Asymptomatic, we can definitely consider the local therapies which are already discussed, and we can still continue with the osimertinib. In case of brain metastasis, symptomatic, if it's a less number of lesions, limited lesions, which can be tackled with the local therapy, still we can go ahead with the osimertinib. Otherwise, we have the options of a systemic therapy, which depends upon the histomorphology. For rarer mutations, we have afatinib and osimertinib as the treatment options, and for a exon 20 insertion, we have abivantinib, ventamab, and mobocertinib as the treatment option when the disease progresses on the systemic therapy. So coming to the data which is associated with, which is there with us with the anti-EGFR agents, TKIs. So we have seen that these drugs have shown significant benefit when they are tested against the or the well evaluated as compared to the conventional chemotherapy. And we know that in the mutant cases of the non-small cell lung cancer, the benefit is much higher as compared to the conventional chemotherapy with the TKIs. TKIs had also been evaluated whether with the first line or the first generation TKIs, or the second generation TKIs with the first generation, or the third generation with any either of the first generation TKIs. And we have seen that even in case of brain metastasis, wherein the symptomatic brain metastasis were excluded, but for asymptomatic, these drugs have shown a better efficacy. And for the third generation, the results were very encouraging, almost reaching 18.9 months. If we see the osimertinib, which has been used in the second line setting when it was given, when it was compared with the platinum and pemetrexed based chemotherapy, it has shown a significant PFS benefit in the AURA3 trial. This trial also gave us a very strong evidence for the CNS metastasis, and the osimertinib or the third generation TKI has a better CNS PFS as compared to the platinum based CT. However, it was 8.5 months as compared to 4.2 months. This efficacy was considering the efficacy of the osimertinib in the second line or in second line setting. It was also evaluated in the first line setting, and we found that both overall survival was improved, which was 18.9 months as compared to 10.2 months in the first line setting. And even with the patients with the CNS metastasis, the PFS was 15.2 versus 9.6 months with the p-value of 0.001. This drug was also evaluated in the OCEAN trial in the two cohorts, that is T790M cohort and the first line cohort. And they have seen that this drug, which was later on assessed by the RACIS criteria as well as the Paraxel criteria, which includes the brain metastasis with the long size was more than 5 millimeters in the long axis, so more than 5 brain metastasis. And they found that it has shown a very significant response. However, the response was also assessed in the type of the or the subtype of the EGFR mutation, and this response was significantly higher in the DEL19 as compared to the other common mutant. So once we started getting good response, we thought that possibly do we increase the efficacy by giving the upfront higher doses. So we evaluated osimertinib in the OCEAN trial. We evaluated the blood concentration of the osimertinib, and we found that the higher blood concentration of the osimertinib do not convert into the improved response rates in the brain metastasis or brain metastasis related PFS. The drug was also compared as a double dose, that is 160 milligram versus 80 milligram, and there was no clear evidence that the higher doses may achieve a better intracranial outcomes. So we had the analysis of FLORA analysis, that is the osimertinib in the first line. So there was a CNS disease progression was mostly driven by the new lesions, and out of this, the fewer patients experience CNS progression in the first line setting osimertinib, and fewer patients progress to new CNS lesions with the osimertinib treatment as compared to first generation TKIs, that is geftinib or erlotinib. The FLORA trial overall survival, we have a very significant overall survival improvement with the osimertinib, that is 38.6 months versus 31.8 months. So this drug, considering the benefit of this drug in the metastatic setting, was also evaluated in the adjuvant setting, and we have seen that whether the patient of the localized disease, whether they were offered osimertinib with adjuvant chemotherapy, that is after adjuvant chemotherapy, or without adjuvant chemotherapy, and we have seen that there was a significant improvement in the DFS rates, both with or without adjuvant chemotherapy across all localized stage subgroup analysis. Tolerability of these anti-EGFR TKIs, these TKIs are well tolerated. There are hardly 6 to almost 15% adverse events which leads to discontinuation of the drug. So these are the very tolerable drugs. Another factor which has led to even more in-depth research in the EGFR how do we tackle the EGFR resistance? As we have found that the resistance is either EGFR dependent or EGFR independent. For EGFR dependent in the second line setting, if there is a T790 mutation, we can always offer a third generation TKI, that is osimertinib. However, in the EGFR independent pathways, we have either the bypass pathways. In case of a targetable mutations, we can always target them. However, we can also target them if there is a small cell transformation of or a immune escape. For a third generation TKIs, we have different mechanisms. However, we have very limited options as on date, but we are hopeful
Bhupesh,
that
sir, sorry to interrupt you. As we are running short of time, can we?
So next is the ALK. The frequency is 3 to 4% overall. Indian population is 4.5 to 11.5%. We have different trials which have evaluated the anti-ALK therapy in the first line setting. We have evaluated crizotinib, the profile, ASCEND, and ALEX, alectinib at the first line, alectinib in the Asian population, and brigatinib. And we have found that there is a significant response rates as compared to the either platinum-based therapy or the first line therapy. These drugs were also evaluated in second and the next line therapy, and the response rates were very good. So ASCEND has been evaluated. ASCEND-7 has evaluated ceritinib in the ALK positive non-small cell with brain metastasis, and we have found that the response rates were significant when there was a ALK naive and no radiotherapy was offered upfront. The intracranial response rates were high. The alectinib, when it was also evaluated in the first line setting, the CNS response rates were higher. The JLX group, which has evaluated it's a Japanese data, which has shown that there was a significant improvement in the brain mets, whether with radiotherapy or without radiotherapy. Alicia trial, also the Asian population trial, has shown significant benefit with the alectinib. Then came the Crown trial, which has proved that lorlatinib efficacy in the first line setting. We have got a overall response as well as the CNS progression rates. Survival without CNS progression are significant with the lorlatinib, and the CNS efficacy has also been higher, as the incidence of CNS progression was 2.8% versus 33% in the crizotinib arm. So the last is the ROS1 fusion, which again is the commonest, one of the common mutations in the younger patients, never smokers, adeno-CA. The frequency is 1.2 to 1.7%. However, the prevalence in Indian population, it is almost 2.8%. Crizotinib has been upfront evaluated in this population. We found that the overall response rate has been 72%, with the duration of response almost reaching up to 1.5 years. Lorlatinib has also been evaluated in this population, subset of population, both in the treatment TKI naive or patients who have received TKIs in the first line setting. And we found that in TKI naive, the response rates, median duration of response, and the ICR rates, that is intracranial response rates, were significant higher as compared to the patients who were exposed to TKIs. So in the end, I would say that we know that hallmarks have increased in numbers. The complexity of the oncogenesis increased, and so are the treatment options, and the diagnostic and therapeutic options or the challenges they have also increased in the non-small cell lung cancer. Thank you so much, sir.